Good afternoon, everyone. Thank you so much for joining us for this webinar that we are doing today. My name is Celestine Jaimbo. I work in IPC department in Kenyatta National Hospital. IPC department is under the healthcare quality department, and in that department we have several other departments that we work together with. And these include public health, patient safety, patient affairs, process improvement, and now IPC. This week, we are celebrating International IPC Week, which started on 16th and is going up to 23rd October. So today, the theme for this year is "The Future is Infection Prevention, 50 years of infection prevention." And in today's presentation, we want to share with you the IPC journey towards elimination of hospital-acquired infections. We have our presenters here, Nancy Tandui, who is an IPC coordinator at this institution, Kenyatta National Hospital. Gilbert Obigi is a public health officer in this institution. Christopher Kibiwot is also an IPC coordinator. Dan Were is our panelist. He works in IDU, but has a lot of knowledge in IPC. And Dr. Rosalind Kinuthia is the HOU in IPC unit. The sub-themes of this presentation include public health in support of preventing infectious disease in the hospital. We are going also to tackle surveillance as an important management tool, IPC audits, and environmental safety, including environmental safety altogether. So our first presenter is Nancy Tandui. So Nancy, welcome.
Thank you, Jaimbo. Yeah, as you have heard, we are celebrating the IPC week globally. And let me repeat, the theme of this year is "The Future is Infection Prevention, 50 years of infection prevention globally." So this is Kenyatta National Hospital. We are going to straight on the presentation. Yeah, just straight to the introduction. It is to mark the International Infection Prevention and Control Week that started on from 16th to 22nd October 2022. The theme, as I have said, is "The Future is Infection Prevention, 50 years of infection prevention." KNH has taken part in this journey since inception, as we will see through the slides. KNH, as you know, is one of the first and the largest referral hospital in Kenya. It is the apex in the healthcare in Kenya, being a level 6 hospital in the city, which is populated, and we receive quite a number of patients. We are happy the government has introduced other level 6 hospitals to support us. But we are the mother. I can say we are the mother. We have, yes, we have the capacity, and yeah, being started in 1901, you can imagine the experience we have. So welcome all. The total staff in Kenyatta cumulatively is about 5,000, and we have a bed capacity of 2,000 patients at our go. The inpatient units in the hospital is 47 in number. The outpatient is about 70. We also have the small ones. We have very specialized care in Kenyatta. We have theaters about 12 to 14 there, and 4 satellite theaters that we run as Kenyatta. We also have a main CCU, and in most of the floors, we have CCU that supports. So when we have patients who really need care, we like the medical CCUs, we have the maternity, we don't want to lose our mothers. We also have the IDU, so we are well equipped, including the newborn units. National IPC, we borrow, for us, Kenyatta, we work in collaboration with the Ministry of Health. We don't just work in isolation. So in the Ministry of Health, we have a department dealing with IPC. And so when things like Corona come and Ebola, we work in collaboration, and we actually have issues and policies that tie together, and we help one another in training and all that. There's also a strategic plan for IPC policy, which was reviewed, which tells us what to do, and IPC guidelines, which was also reviewed in 2018. In line with the National Infection Prevention Guidelines, we have, in Kenyatta, we have a Infection Prevention and Control Committee, which has 20 members, which has, who they are selected by the board. They report to the hospital in case of any concern that is touching the patients and the staff, and which needs attention to the board. So it is really active, and it has really helped us in managing issues which are of importance as IPC. So we also have members in the IPC and a secretariat. We have a unit in second floor Kenyatta, the own hospital. We also have capacity. We have trained the IPC coordinators in Kenyatta. They have been trained internationally in South Africa, and they have come with first knowledge to help others, even the link persons whom we have on the ground. We have 2 trained by the MOH2 on epidemiology and other aspects of IPC. Infection Prevention Control Unit was started in 1974, and activities conducted by the nursing office then. Several years later, an IPCCU was constituted to oversee the IPC matters. The IPCC was constituted in July 2010, and in August 2012, a need to make it an active and a robust program in Kenyatta was actually just started from there. Is a very active unit with a trained staff. A benchmarking was done in South Africa, which up to date, if you come to Kenyatta, we have a very active IPC, which is really important, especially now that we are ISO certified. In February 2012, the Board of Management granted the IPC unit an autonomy to work by itself, but reporting to just like there are bigger units called the HCQ. In how it was established, we have a HOU. It's headed by an HOU, who's a doctor. And in this case, we have Dr. Kinudia at the present. We also have our lead coordinator, Mr. Christopher Kibiwas, who is an epidemiologist. We also have other coordinators dealing with department with specialties in various areas in the hospital. There is a secretary and a support staff to run the IPC. Our IPC unit is, we have a vision whereby it's a world-class unit in advocacy of IPC practices. Our mission is to promote safety in the hospital and community through IPC practices. And if you talk about the community, we go even outside. We go to schools, we do programs, even, giving health education, patient education, the children, we talk to them, we go to schools and perform hygiene, we train them in that area. So our mission is in line to what we do. So our motto is infection-free for better life. IPC unit strategic objectives include to enhance IPC advocacy, collaborate for IPC standards improvement. We also have, we improve IPC surveillance through audits, which we do in this hospital. We improve human resource capacity, like for training, yeah, taking our staff to be trained so that they give knowledge. You know, you cannot give something you don't have. So that is what we do. Monitor and offer technical support on IPC related supplies. For example, when we go around our hospital, especially during the COVID-19, it used to be very tough. Our staffs were concerned. They were asking us about the IPC supplies. So that is where we also advocate and offer support and even advise the relevant authorities who support us as IPC. We also optimize customer experience. We want our patients, when they come to the hospital, they don't go to, or when they're in the hospital receiving care, not to also get infections which they didn't come out with, which they didn't came in with. So that is we optimize our experience. Yeah, that's just a pictorial of what I've just said orally. Yeah, so the administrative structure include, we are under the Senior Director Clinical Services, Director Healthcare, that is where we report. We also have the Head of Unit, Infection Prevention Unit, and we have the Lead Coordinator, and then Departmental Coordinators. Then we have the link nurses, or not really the nurses, we call them the link persons, because they are from different units. You could get a microbiologist and occupational therapy. So we have people on the ground who they alert us on issues. We also train them on different issues, and they report to us as what is happening on the ground and which needs our eye. The purpose of IPC is to enable provision of quality health care. We also promote patient safety, making sure that our patients are safe. Yeah, they are, when they come here, they don't get experiences which they do not deserve. We reduce occupational hazards, like even fall associated with health care, yeah, or even medical errors. Yeah. Also functions including, we do support supervision as the IPC coordinators. We perform audits, not limited and including the hygiene audits. We do it biannually, and we do it scientifically, using the moments that we borrow from the WHO. We also we do county, we also do FAB, ventilator-associated pneumonia bundle. We also do SSI, surgical site infection, and we also do CLABSI, central line associated bloodstream infection. So those are the things we do on the ground and more so.
So thank you so much, Nancy, for that good presentation. Our next presenter is Christopher Kibiwot.
Thank you, Jaimbo. So we are taking over from what Tandui has built on. She has made a good introduction of what IPC is. And as it is, our mission is to make sure that we don't have infection in the hospital. We have had this long journey from 1974. We started small, but now at least we have expanded as IPC. So we have the pillars of IPC, which are actually 4 in number. We say they are pillars because IPC cannot stand without the 4. So the first pillar is administrative support, which I'm going to elaborate shortly. We have the engineering and environmental control. We have protective control, and we have training, research, and surveillance, which has come to take a very big chunk of IPC in Kenyatta National Hospital. So when we talk of administrative support, here is what the management does to make sure that IPC remains as vibrant as it should be. And as is recommended, WHO is actually recommending that In a hospital with 200 bed capacity, there must be one IPC coordinator. So like in our setup now, Kenyatta National Hospital with a bed capacity of 2,000, ideally we should be having at least 10 IPC coordinators. That is excluding the HOU and the secretaries and other support staff. So that is what the management has tried to do. And right now, as IPC, I think we are almost full to capacity. The other aspect which administrative support does is to empower the staff of IPC. As Nancy had said, when the IPC was formed, as a very good measure to make sure that there is no infection in the hospital among the patients, is to empower the staff. And that one, the management did by making sure that they are well trained to tackle IPC matters. And it has been mentioned before that some have been trained in South Africa, and some have been trained locally through the collaboration with our Ministry of Health. So that is another aspect of management. Then an organization cannot work without guidelines and policies. So that is what the administrative support has been. That's why as IPC unit, we have guidelines and we have policies, which were derived actually from the national policies and guidelines. Other factors for administrative support includes equipment. It is the work of the administration to make sure that the equipment are available to run IPC appropriately. The procurement of related supplies is also another core business of the administration. The maintenance, repair of IPC infrastructure is also a very important role that the administration does. And there is involvement of IPC in all infrastructural developments. That is something which has been happening for the last few years, whereby we decided that we don't need to come around after a building has been completed to start saying that it does not have a certain number of things, it does not have good isolation facilities. So the management saw it that IPC should be involved in infrastructural developments from the beginning. So that's why the administration comes in. Then there is support in creating isolation units. And in KNH, we have two crucial isolation units. One is for the infectious diseases. That is why we have the infectious disease unit. And this is a unit which was equipped to handle conditions like the Ebola, like COVID-19. We also have another important isolation unit for multi-drug resistant TB in the hospital. And the management is always looking at IPC to see whether we need another isolation or not. And that is what we call administrative support. Then the other pillar is what we call engineering and environmental control. This is a very important pillar for IPC. And this is surely the first defense for both patients and staff. With engineering and environmental control. Includes correctly designed units, ensuring zero or little contamination. It also covers what we call patient flow and staff flow, so that whenever we have any infectious disease, there is very limited coming together of those infected and those ones who are not infected. Then we have the physical and non-physical barriers. In this case, we may have physical barriers, meaning you cannot go beyond a certain point because there is a wall or there is a barrier, a physical barrier. Then we may have non-physical barriers where in some theaters, we realize that we have a red line that is still a barrier, making sure that you don't pass through a certain red marked barrier. Then we have the environmental cleaning, which is going to be tackled very well by our colleague here from public health. Then the third pillar is what we call protective control. And in protective control, there is usually an hierarchy for these controls. You can see, look at that figure. The red means least effective, and the green means most effective. I am sure most of us think that when we talk about protective control or protective control, we mean just personal protective equipment, which is not actually the case. So the hierarchy starts from elimination. What do we mean by elimination? It means we physically remove the hazard. If the hazard is not there, actually the risk is also zero. And this one is done very well by environmental engineering. Then we have what we call substitution as the next in the hierarchy, which is replacing the hazard. In this case, we mean instead of encouraging reuse of a certain component of patient care equipment, why don't we just use a disposable one? So that is what substitution means. We don't need to reuse some ambu bags. Instead, we just throw them away and get new ones. Then another aspect of replacement is like in newborn units, you have realized that sometimes we reuse syringes. So we don't need to reuse the syringes, we just replace. That is substitution. Then we have the engineering controls, whereby we have the isolation units like the ones I have just mentioned, where we isolate those people who are infected from the ones who are not infected and treat them in that isolation facility. So that is still part of engineering control. Then when it comes to administrative controls is when the management comes in and change the way people really work. Here, a good example is when it comes to allocation. If you are a theater nurse, you are better off working in theaters instead of being taken to a medical ward. If you have trained in newborns, it is better for you to remain working in the newborns. So that is still administrative, because when you take somebody who has been working in theater to the wards, they may not be able to catch up very well with what is happening in that ward. Then our last, which is actually our last resort, is always the use of personal protective equipment. And as IPC, we always insist that we use PPE where it is necessary. We don't just put on a PPE for the sake of doing it. So PPE is very important when it is used appropriately. And always it depends on the risk the staff is facing. So when you are dealing with contact-based pathogens, you don't need to be putting on masks and all full body suit. When you are dealing with the droplets, the only protection you may need is just a simple mask. That what comes into example now is the COVID-19, which is still on. So what we just need is a surgical mask, and we are good to go, because it is a droplet infection. So remember, when we talk about PPE, personal protective equipment, you look at the risk, not just putting on the PPE for the sake of it. Then the fourth pillar, which is the last one, is what we call training, research, and surveillance. Without training, there is no way IPC personnel can always come up with new knowledge. And this one is done through continuous medical education to staff, and including the staff of IPC. It is also done through audits of hygiene, infrastructural audits. It is done through surveillance of hospital-acquired infection and multi-drug resistant organisms. It is also done through conducting annual research on subjects picked from surveillance. We always, during our surveillance, we realize that there is a problem at one point. That is what we make now to be the subject of our research. Because at IPC, we have to produce at least one research every year. For this year, I think we are doing little prick injuries, which the results will be coming up soon. So IPC is also part of research teams across the hospital. So whenever there is a research being done on, let's say, surgical site infections, an IPC person must be there. When a research is being done on ventilator-associated pneumonia, an IPC person should be there. And that is why we form a very important part of research teams in Kenyatta National Hospital. Then after doing the pillars, let us define our real business, which is hospital-acquired infections, which these days has been said to be hospital-associated infections. It has become better to be called hospital-associated infections. So what is an hospital-acquired infection or hospital-associated infection? It is an infection which occurs from 72 hours, that is 3 days of admission, up to 30 days post-discharge. And there are several types of hospital-acquired infections. There are usually 4. We have catheter-associated urinary tract infection. which is shortened as tauti. And this is a kind of infection which occurs because of being inserted urinary catheter. We have the ventilator-associated pneumonia, which comes as a result of being in a ventilator. That one happens mostly in our critical care units. We have the central line-associated bloodstream infection, also called CLABSI, which occurs as a result of being inserted line getting into the bloodstream. Then we have the surgical site infection, which occurs as a result of undergoing any type of surgery. So surveillance data can be used to estimate the magnitude of specific hospital-acquired infection. And IPC has actually embraced surveillance these days as a very important tool towards informing where intervention can be made in IPC matters. So this is an example of the trend of hospital-acquired infection. And you can see from July, it was 9.7, August 8.7, September 9.4, October 7.1, then November 7.3, and December 7.4. This was achieved through what we call surveillance, so making sure that we monitor the fog and we take appropriate action as the graph tells us. Then during the surveillance, we are able also to pick which are the most troublesome organisms. And an example in this chart, if it is E. coli, we make sure that we design methods of tackling the E. coli. And again, we go beyond that to know whether is it contamination of the samples or is it truly the E. coli. We have the Klebsiella, we have the Staph aureus and all that. As Tandu had mentioned earlier, we do what we call outbreak investigation and actually monitoring outbreaks. This chart shows how we were able to establish and track COVID-19 among our staff. And you can see what the graph is telling us. And this one is telling us exactly how the national trend was like. And that is the work of IPC, to make sure that at any given time, we make sure we know which disease is rampant in the community and in the hospital and take the appropriate action. So infection prevention control standard precaution is what encompasses all the above we have just said. And it includes a few of the following. Hand hygiene. We don't need to re-emphasize about hand hygiene. It is a very important tool of making sure that there is no spread of infection from one person to the other, from the staff to the patient. And hand hygiene is said to be very effective in minimizing or reducing spread of infection by up more than 80%. And that's why IPC many times seems to be associated with hand hygiene alone, not any other thing. So use of personal protective equipment is another standard precaution. And I have mentioned earlier that before you use any personal protective equipment, assess the risk. There are many procedures you may need to do without necessarily having a PPE. And there are some you can never do without a personal protective equipment. So what is important in this aspect is the risk and the type of PPE to use. Then in IPC, another part of standard precaution is what we call cough or respiratory etiquette or hygiene. This was very important during the COVID-19 pandemic, especially the respiratory hygiene. And that is how we came up with many measures of how to cough or how to sneeze. So that is important. This one is basically important simply because the spread from respiratory system is always very fast and very easy from person to person, unlike the contact. For contact, somebody has to get into contact with you, but for respiratory, it can affect you even if you are seated or walking a few meters away. Then another aspect of IPC standard precaution is injection safety. In our hospitals across the country, we have a lot of reported cases of needle prick injuries. And you know, needle prick injuries comes with a lot of risks of contracting deadly diseases like the HIV, the hepatitis B, C, and the others. So that is why it is a very important aspect in standard precautions. And that is why in the hospital, we always make sure that we have the safety box. We teach our staff always how to dispose the sharps. And the sharps here that does not mean only the needles. It also means the blades and anything which has been in contact with the patient and it is sharp. Then we have what we call instrument reprocessing. After all has been done in the clinical areas, in theaters, we need to devise a way of making sure that the instruments are safe for the next patient. So that is a very important aspect of IPC standard precaution. And we take a lot of pride in making sure that the process is working seamlessly in the hospital from the ward all the way to the sterilizing unit. Then we have the environmental hygiene and waste management. That one will be talked more by our colleague for public health, Mr. Obegi. So those are what we call the standard precautions, which should be applied across all the hospitals in the world, not only in Kenya, the standard precautions. And I can assure you, if as our healthcare worker, you follow the standard precautions, you'll always be safe from any infection. And at the same time, we'll make sure that our patients are very safe from getting any infection from another patient or from the healthcare worker itself. Then we talk about the successes of IPC, because the topic suggested that it is a journey. We have had a very good management support, which is key, because an organization or a department cannot work effectively without management support. We have had the opportunity to be guided by experts. Here, I mean the CDC, the WHO, and that is how we derive most of our operation terms, the CDC and WHO. We have had collaboration with other institutions and departments. We have had collaborations with hospitals around Nairobi. We have had collaboration with hospitals outside the country. And within the hospital, we have had very good collaborations with the public health, with patient affairs, with the nursing department, and all that. So collaboration has been a very good success for IPC. Then another success is that we have been able to be proactive on action against hospital-associated infections and multi-drug resistant organisms because of improved surveillance. We have made very good surveillance, and we can be able to tell which outbreak of a certain organism is going to come out soon after studying daily data from our laboratory. Another important partner which IPC has been able to work with very well is the laboratory, the microbiology lab. Then we have had capacity building, whereby we have had trained IPC staff who can be able to collect data, analyze, and be able to disseminate for action. So that is why IPC is able to perform some outbreak investigations and take appropriate action. Then because of that experience and because of that support from all the departments, we have been able to have better management of outbreaks. Of course, we cannot say we don't have challenges as IPC. The challenge we have been having is the numbers. That is the patient to caregivers ratio. As we know, Kenyatta National Hospital is a referral facility, so we are likely to get a bigger share of patients from across the country. So that one has been a challenge because it affects IPC in one way or another. Then we have had the long problem of attitude, the change of attitude among healthcare workers. But we are happy as IPC that this year the hospital has put culture change in its DC. So we are likely to see at least change of attitude from the healthcare workers. This one can be attested by the under-genes we do, year in, year out, and we have never been able to go beyond 50%. So we have had challenges like lack of IPC involvement, especially in procurement, which has affected the IPC-related supplies. But I'm happy to say that of late, we have been involved in one way or another in terms of procurement. Then we have had a regular supply of under-hygiene commodities, like the one anti-hygiene soap and absorbent paper towels. So those are the challenges which IPC has been facing over a period of time. So I finish by making this quote: the new leadership will not be provided by take charge elite, but will emerge from the capacity that lies within each and every person. Again, it will be leadership that does not presume to have all the answers, but one that seeks to empower others. That was by Annabelle Virel. Those are very important quotations which keep IPC moving. Thank you very much. Back to the moderator.
And in that empowering others, let us hear from Gilbert Obegi, the public health perspective in the reduction of healthcare associated infections. We are requesting you to be posting your questions online so that we can answer them at the end of the presentation. We have been told that you will be shared the CPD points token at the end of the presentation. So we have noted your addresses and actions will be taken. So now, let us hear from Mr. Gilbert Obegi.
Thank you very much, Sister Zilembo. From public health, basically public health as a unit within healthcare quality. The first thing is that we ensure clean, safe working environment, whereby public health has various pillars which guides us as far as to achieve what entails. So maybe to go through the pillars, let me just brush through the pillars, whereby we have 5 of them. The first one is public health infrastructure, where we have occupational health and safety and environment to ensure clean, safe working environment, climate change, medical waste management. And again, the second one is where we have health education and promotion, where we conduct disease surveillance and notifiable diseases within the hospital, of which public health is a link within the hospital and the Ministry of Health as entails. We also carry out what we call prevention of communicable diseases and non-communicable diseases within the hospital, disaster management, vector, vermin, and rodent control. The other key component pillar is public health laws and other related laws, where we ensure that we conduct the audits in line with the law, of which we conduct various audits, which includes environmental audits, occupational health audit, fire and air quality audits. And also we are the link person or other entitled to ensure that licensing of the workplace is conducted. And in line with the NEMA guidelines, we ensure licensing of our incinerators and the microwave plant. The other pillar is on food quality control, where we ensure safety of the food that we give, especially to our patients within the hospital. And lastly, just to highlight on the pillars, lastly is monitoring of the quality of services and the products that we receive within KNH, where we conduct service swabbing and sampling of the products that we receive to ensure the efficacy, where we conduct the efficacy testing to ascertain the quality of the products that we receive within the hospital. We also mandated in the issue of coming up with a specification of those products and quality, the products, and monitoring them through inspections to ensure that we give the hospital what it actually deserves. So to go back to my slides is that, as I alluded, is that clean, safe work environment, that is our commandate, whereby we've been supported through our division of healthcare quality, where the director, our director, Lead of Toy, has been spearheading the spirit of teamwork, and hence we've achieved the enormous activities within that division. So from the slide, you can be able to see our other core function is medical waste management. You are able to see the modern technology of waste management, whereby we've turned from basically the burn system to non-burn system. That is a demonstration of a microwave, which manage our waste in terms of treatment of our waste within the hospital. And we've done some emphasis as far as segregation of medical waste is concerned, from the generation point, where we work as a team from the clinician to the handlers, and then finally to the treatment aspect of medical waste within the hospital, which is a key component as far as infections preventions are concerned. Then the other slide is on clean and disinfecting services within the hospital. You can testify with me that is one of the wards within the hospital, and you can agree with me from a look at it is that how clean the hospital is. We actually from KNH, we can brag that the hospital is clean compared to other hospitals within the country, and whereby we've put some more emphasis as far as environmental sanitation is done, being guided basically with coming up with the standard operating procedures on cleaning, which guides our people, and SOPs on disinfection, dilution ratios, because if we get it wrong when it comes to dilution factors, then it means we are doing zero work as far as infections controls are concerned. So we, as a unit within the healthcare quality, we work hand in hand with IPC to ensure that indeed we give the standard dilution factors on our detergents and disinfectants. And from the common disinfectants that we use, hypochlorite-based disinfectant, the common JIC, whereby we guide our people when cleaning, especially when cleaning, to use the dilution factor of 1:4 when doing the cleaning in our highly infectious areas, that is the bathrooms, toilets, and in case of any vomiters or sputum along the corridors, we encourage them to use a ratio of 1:4. And when cleaning the patient rooms, that is wards also, and along the corridors, we encourage them to use the dilution of 1:6. And when it comes to the offices, the dilution of hypochlorite-based disinfectant is 1:10. So we emphasize that because of prudent usage and ensuring that indeed we are doing justice to the work that we do. Also, the other disinfectant that we commonly use is disinfectant cleaner, that is quaternary ammonium, which is basically, if you happen to walk along the corridors or rather the wards within the hospital, you can agree with me the ambience that is there. This chemical is basically allows or rather camouflages the odors within the wards, and that is why most of our wards actually don't have the odors when you walk along them. And the dilution factors are there, where we guide them in the dilution of a ratio of 1:4 and a ratio of 1:6, depending on the areas where you want to use when cleaning. The other one, the common one, is the enzymatic cleaner, commonly known as Rufex. This is basically decontamination when we carry out decontamination, disinfecting, and the services, especially the hospital equipment. We advocate that because of the corrosiveness on our equipment. So we encourage the ones who are using to use with the proper dilution of 20 ml in a ratio in 20 ml to 1 liter of water. And of course, basically we have the precept, which is another disinfectant, hypochlorite disinfectant in the solid form, which comes in form of tablets and granules and we also advocate it in the ratio of 1 tablets to 5 liters of water. So basically, that is what we do, and I'll end my short presentation with a quote from Anonymous, which indicates 4 beautiful thoughts of life. You need to look back and get inspired, experience. Secondly, you look forward and see hope. Look around and find reality, and look within, you'll find yourself and be able to work and ensure we have a clean and safe environment. Thank you very much.
Thank you so much, Mr. Obegi. We all agree that we now know that public health is a very good component also of infection prevention and control. Those are the 3 presentations that we are having. We are now going to take the questions that you have raised in the chat box. We have a panelist, Mr. Were and Dr. Kinuthia. And there was a first comment by Sheila Mgendi, who said that IPC is a backbone of health, which we all agree that IPC indeed is a backbone of health. There's a question from Josephat Masinde that is asking, what are the components of audit forms that are used for auditing? The components of audit forms that are used for auditing. So I'll let Mr. Kibiwot answer that.
So the components of audit forms depend on what type of audit you are going to do. If you are going to do an audit on anti-hygiene, we are actually auditing the 5 moments of anti-hygiene. And we all know that it is before touching a patient, after touching a patient, before clean or aseptic procedure, after touching patient's environment, and after exposure to body fluids. So those are the components we audit. When we are going to audit the infrastructure, the IPC infrastructure, of course, we audit things like all the anti-hygiene facilities, from the tap, the availability of soap, the availability of alcohol-based tap. Those are the components that we audit. If we are going to audit the contamination, it is the entire process from the point of use. After a patient, staff has used a certain instrument, it is all the way to CSS. So that those are the components. So the components differ from one activity to another. So I hope I have answered you well.
Thank you so much, Mr. Kibiwot. Another question. Good presentation so far. Stephen here. My question is, how often do you conduct SSI audits? Is it continuous, or there's data collection for say 3 months and then followed by analysis and RCA?
Okay, maybe I can answer that one also. It is surveillance, so it is continuous. For Kenyatta National Hospital, it has always been continuous surveillance. So we take data every day and we analyze, and because of that surveillance system, we can be able to tell you in a month of January of 2020, we had this and these infections in the hospital, and we can be able to tell you cumulatively. So it is surveillance, so it is continuous. That is the beauty of doing surveillance, because you can be able to compare different months, you can be able to compare different years, and you can be able to tackle the present. So our surveillance is continuous.
Thank you, Mr. Kibiwot. Barry is asking, kindly clarify on timeline of onset of HAI. Is it 48 hours or 72 hours? Please, Mr. Were.
According to CDC, that Center for Disease Control, the timeline is just as you have said, it is 48 to 72 hours. 48 to 72 hours. That's the time.
Thank you so much. 48 to 72 hours. Dr. Kinuthia, there's a question here for you. Why don't we have representatives of IPC in every ward? Because this is a very important area in every healthcare setting.
Thank you, Celestine. I think from I'll pick from what Nancy presented on how the IPC program in KNH is structured. So at the moment we have a unit with a head of unit and 8 IPC coordinators. So because our hospital is large, we cover big sections. Each coordinator covers a big section, like there's someone covering general surgery, there's someone covering medicine, and in a similar way, all the areas of the hospital. And that's why we have what we call the link persons, IPC link persons. These are part of the wards, staff who work in the wards, but we use them as our champions in their areas of operation. So ideally, each ward should have an IPC link person who is part of the staff in that ward. And we actually do training for these link persons so that they have an idea of what they're supposed to do in IPC. So if your coordinator is not available because they are covering a whole section, then there's a link person in every ward. But again, Paul, if you need to reach out, we can have a further discussion, know which ward this is that is having, if there are issues, and then we'll have you covered. Thank you very much.
Thank you, Dr. Kinuthia. We have another question. In many health facilities, guys who handle hospital waste are not professionals. I'll request Mr. Obegi to answer that.
You are right. In many hospitals, they are not professionals, but within KNH, we have actually the ones who are handling the medical waste are trained. We've taken them various trainings on how to deal or rather handle the waste after generation, and even more so on the treatment part of it. We've intensified, or rather the hospital has intensified or rather put more resources on the training of those waste handlers. So basing on that, KNH, I think we are much better leveled as far as our staff are concerned. Thank you.
Mr. Obegi, there's another question here on dilution. It is asking why the different dilutions in different places, and I'll marry it with another one that is saying, I thought the ratio of JIC is 1 to 5.
Yes, we factor in the dilution factors basing on the rate of, or rather the levels of infections within. You can't compare the levels, or rather the levels of infections in the toilet, or rather in the sluice room and in an office. So basing on also on the strength of the detergents and disinfectants that we have within, we are guided by the WHO guidelines on the dilution factors. That is why we've come up actually with the dilution factors that we've given you today. So basing on the infections rates at a particular place, that is how we've broken down the dilution factors as they are. And not basically 1 to 5 as you've alluded. For example, if you get a vomiters, or rather blood spill, we won't be able to use the dilution of 1 to 10 because that one has been tested, and basing on the efficacy test, That is why we use the dilution factors as guided by the WHO. Thank you.
Okay, next question. I'll request Nancy Kandui to answer. What measures do you have in place for control of infection transmitted by the lab coats or white coats from one patient to the other?
Thank you, Celestine. What we say about lab coats? I think lab coats generally have been misused, but it's supposed to be a PPE and addressing to protect you, because whoever is wearing the lab coat, they also have their own clothing. As much as we prefer to have the scraps, which actually, yeah, you know, they are not loose and they don't touch the patient's maybe bed, the curtains. When you're performing your activities or performing any procedure to the patient. So what we say, let them be very clean, let them be washed if it is possible in the hospital, and also be dried well, and even if possible be ironed. But you find that most of our staff or people, sometimes they can reuse it. You know, we are also individuals, and people sometimes do what they feel like doing. But we say the lab coat should not be below the elbow. So we advocate that the lab coat be not below the elbow, so that you prevent yourself from touching the patient environment or even contaminating yourself further.
Okay, thank you so much. There's a clarification that is being requested for here. Please clarify the recommended ratio of IPC coordinators to beds. According to WHO, one IPC coordinator to 250 beds. Mr. Kibiwot.
Okay, thank you, Jaimbo. The recommendation is actually one IPC person to 200 beds. So our hospital with 400 bed capacity should have 2 IPC officers. And that one excludes the in charge. It is the people who should be operational on the ground.
Okay, thank you. Dr. Kinuthia, there's a question here. Do we have community health volunteers there? And I'm assuming here it means KNH.
Community health volunteers, I am not aware of that unless Mr. Obegi knows.
Within KNH, basically we don't have them. What we have is specialists or other people trained on public health who are employed on a temporary basis to support where we have the gaps. So if that one equates to community health workers, I don't think so, but ours are actually trained and are engaged basing on the gaps within the hospital. Thank you.
Okay. Mr. Obegi, there is a question here also. Is it recommended to use Lysol disinfectant in the hospital? 1. 2, is burning of waste within the health facility, within the health setup healthy, considering poor segregation of the same, e.g. blood and other objects which are poorly or wrongly placed? And yeah, I think you can take that, those two first.
Good. One, we are asking whether we are allowed to use Lysol within the hospital. No. The approved research is that they are carcinogenic, so they are actually banned, and we scrap them from our list of the products that we procure within the hospital. The other question is on open burning. Actually, open burning in line with the NEMA guidelines, it is actually banned. We are not recommended to do open burning unless you are using a standard incinerator that is actually licensed by NEMA, of which KNH is lucky. We have 3 of them of which out of the 3, 2 are actually licensed to be used as a burning system. But as I alluded earlier in my presentation is that we are now turning from burning of our waste to microwaving and shredding of our waste. So we are trying as much as possible to comply, but where need be, we usually use the licensed incinerators which have been licensed by NEMA. I hope I've answered your question.
Thank you, Mr. Obegi. Sheila Mgendi is asking, after sluicing and disinfecting, are the reusable packs to be cleaned with soap and water before taking to CSSD? Mr. Were?
Okay, Sheila, I hope you're talking about instruments. Yes, with the introduction of enzymatic cleaner, the enzymatic is already a detergent, and so there is no need for use of soapy water. From enzymatic cleaner, this equipment of the parts will just be taken directly to CSSD for sterilization.
Okay, another question. Just wondering, what liquid was used for spraying within the hospitals and other clinical areas during the COVID pandemic?
Maybe to answer that is that the hypochlorite-based disinfectant cleaner is basically what we were using, which was being recommended on the services and high services. But when it comes to the equipments, on equipments, we are recommending the zymatic cleaner. The commonly one that we use within KNH is Rufex. And of course, basing on the dilution factors that I gave earlier on. So hypochlorite-based disinfectant cleaner is the one that we were using during COVID period.
And then where do you check air quality? Again, Mr. Obegi.
Air quality, what we normally do is that we have the companies that are being licensed by NEMA, of which we subcontract to do the air quality, of which at the end they give us a report. And if there are gaps within the report, the hospital management has been supportive or other supporters in trying to do some corrective and preventive measures as far as the findings from those reports. So we outsource the services.
Okay. Another question from anonymous attendee. Thank you for the presentation. I wish to know how KNH manages the power bill for the microwave. We have one and we can't manage it due to the power bills.
Yes, I can testify that it is a challenge. If I tackle that from the aspect in that the quantities of waste that we generate, basically within KNH, on a daily basis, we generate 3 tons of clinical waste. So within a week or a month, you can see the higher quantities of waste that we generate. So if we were to outsource the incineration or rather the treatment of that waste with outside the hospital, basically the hospital will use more resources or rather to pay in the management of that waste outside the hospital. So vis-a-vis the comparison within of the waste that we generate and the amount of money that we can use to treat that waste outside the hospital, there is value for money when we basically use or rather pay the bills as far as the consumption of electricity on the microwave that it uses. So we check on those 2 variations, but I totally agree with you. The cost is high yes, the cost is high, but we are able to manage through the support of the hospital management. Thank you.
Another question from Julie Obui. How are we supposed to isolate our patients with neutropenia, especially in oncology wards where there are no side rooms or individual rooms that can serve that purpose? Mr. Were?
Right, in this case, since you have mentioned that there are no side rooms or rooms where for single patient isolation, there is what we call cohorting that can be applied. Maybe patients with similar conditions can be put together because these are patients who require protection from either contamination or any other exposure to infections. So you can cohort patients with similar conditions in one room. That's the only way you can address the number of many patients with limited space or rooms.
Okay. Thank you. Judging by the number of questions, it seems that this was a really timely presentation. But there's somebody who is seeking clarification from Mr. Obegi. What happens to the shredded and microwaved waste? Is it recommended to shred and microwave infectious and highly infectious waste?
Yes, indeed, it is recommended. This is a plant that has been tested and approved by the Kenyan authorities. So what normally happens is that we are still working on the research on the end product from the microwave and the shredded waste. We are trying to investigate, or rather we are working on coming up to reuse or rather use the end product in making the blocks. We are working hand in hand with the various factories of which they've actually sampled the end product to see if it can indeed work with especially the cement factories to come up with the blocks. That is one area, but indeed it's a challenge for now of managing the end product. But in comparison to what we used to get the end product from the incineration, we are much better in comparison with the microwave end product.
Okay, the next question I'll give Mr. Were. How do we handle spills in IPC? There are two questions about spill management. Mr. Were, please.
Now, spillage could be maybe body fluid, and that is infectious. And again, there is always a pack that is used for management of spillage. And what is recommended mostly the granules, which could be the hypochlorite granules, which is spread on the spillage, and then there's a special scoop material or equipment that is used to once it has absorbed the spillage, then it's scooped and then taken into the waste bin or any other waste container that's available.
Okay, thank you, Mr. Were, for that answer. Dr. Kinuthia is somebody who is saying, I like today's topic. Do more detailed ones, especially on care bundles, SSI, Kauti, Club C, and VAP.
Thank you. I believe that is a comment and it's well taken. It's actually a great comment. As IPC, now that you're talking about the journey to eliminating or reducing hospital-acquired infections, one of the key solutions is to ensure that care bundles are being adhered to. So we have been doing a lot of sensitization in the hospital on care bundles for the 4 different types of hospital-acquired infections. And yes, I agree, we will organize more sessions on the same so as to reach a bigger audience on the same. Thank you very much.
And just as you, before I let you go, my concern is about, I think you'll answer this, and also Mr. Obegi will add. My concern is about outsourced cleaners in the hospital. Are they taken through IPC session before being allowed to clinical areas?
Right, thank you, Celestine, once again. Yes, I believe Mr. Obegi will add on this, but yes, when we have new teams in terms of cleaners, we take them through IPC training. I think it's quite a number of hours, but we have a challenge, of course, because of turnover in terms of when the ones that are already trained leave for various reasons, then we need to keep doing more trainings and retraining the ones that come in. But yes, we have that provision. Mr. Obegi?
Yes, I totally agree with you, Daktari, is that it is part of the requirements on the contract, in that before we engage them, or rather before they start working, they are inducted and trained on key aspects as far as IPC is concerned and public health before they are engaged on their work.
Thank you, Mr. Obegi. Dr. Kinuzi, another question for you. I don't know whether you'll be able to answer this, but what is saying, we have expired drugs in government hospitals of which have accumulated for years. Kindly comment.
All right, so that's an issue of disposal again, and drug disposal. And I believe that the counties have various ways of how they organize for disposal of expired drugs. So I think this is something that can be managed at that level. As a hospital, we constitute board of survey when we have expired drugs, and we are able to work with organizations that are able to dispose of expired drugs. And then I know there are also quite a number of organizations out there. Actually, if you Google, you'll find some, and I think the costs are bearable. You can be able to work with such organizations to help you dispose of your expired drugs, because they have to be handled in a particular way. We don't just dispose them anyhowly. So I don't know if Mr. Obegi would also want to add on that, on disposal of expired medicines.
Yes, within the hospital, as you've alluded, there are guidelines which guide us on disposing the expired drugs. And actually, we on an annually basis, we do that. And also there are laws which guides on how to dispose various expired drugs. So one can also check on that. But what you've alluded is actually right.
Okay. What is the recommended SSI surveillance duration for implants? Mr. Waring. What is the recommended SSI surveillance duration for implants?
Oh, for implants, when we talk of hospital-acquired or hospital-associated infection, for any implant, it can be considered to be hospital-acquired up to 6 months. Up to 6 months. So if you get an infection within 6 months of implant fixation, it is still considered to be hospital-acquired. So that's why it goes from 48 hours to 6 months when it's an implant. But if it is any other procedure, it is just within a shorter time.
Time is not on our side. We will check the last 3 questions. How do you dispose of your vials? I'll ask Tandui to take that.
Yeah, for the bottles and the vials, if the vials are big, they can be recycled according to institution, you know, they usually say recycle and reuse. So, but if it is broken, remember that you'll have to handle it as a sharp, because it can even, the handlers, those who are disposing, can also get hurt. So we usually put them sometimes in a separate box if they are small ones and they are not broken, and then they are taken care of by the public health. Yeah, so basically that's what we do.
The second last question, Mr. Obegi, name of company doing the air quality check. I don't know whether it's okay to
Yes.
mention the name.
There are several. We have a number of them, and basing from the NEMA website, they are listed. They're actually 100 plus. So if you go to NEMA website, you'll be able to get them and engage them directly. So the main thing is that we engage the ones that are approved by NEMA.
Okay, and the last question, which is the best solution to clean CVC to prevent clubsy? Dan? It is chlorhexidine with alcohol, which is used. So this is the best solution that it is used, chlorhexidine with alcohol in it. And every time we are dressing a CVC, we always advocate that we use a sterile, transparent dressing. And there are care bundles on Club C, and just as somebody has requested that we do another presentation that is detailing the healthcare associated infections. And we are going to take that into consideration, and we will address all this, including the best solution to clean the CVC. Thank you so much for all attending. I will request all my presenters and the panelists to give their final remarks. I'll start with Nancy Chandui. Please, your final remarks, Nancy.
All right, thank you so much. In IPC, we say IPC is everyone's business. So even as we come to where your areas, or even I know we have audience from outside, let everybody know that we need to take responsibility in IPC. Let's approach our management in a friendly way to provide us with IPC supplies to be able to practice IPC scientifically.
Okay, Mr. Kibiwot.
Thank you guys for attending today's webinar. My parting shot is, let us use evidence-based IPC through surveillance. That way you can achieve better results.
Mr. Obegi.
Thank you very much for the opportunity today to view on, or rather to present on public health. My parting shot is from Abraham Maslow, which quotes that one can choose to go back towards safety or forwards towards growth. But growth must be done again and again. Fear must be overcome again and again. Thank you.
Mr. Were, your parting shot.
That IPC is everyone's business.
And my parting shot is that the future is indeed infection prevention. Let us all adhere to the IPC prevention protocols. Thank you so much, Dr. Kinuthia. I will give you the last chance as you close for us the webinar.
Thank you so much, Celestine, and indeed for the entire team, Nancy, Kibiwot, Were, and Obegi. I think this has been a very productive session and very interactive. We thank you as our participants for being with us. Again, as we remind you, we're doing this in celebration of International Infection Prevention and Control Week. And our request is that you'll continue to support us, even as we walk this journey of trying to minimize and reduce hospital-acquired infections. Wherever we are, we believe we are all IPC champions. Please take up your roles. Please look out for your colleagues who are not adhering to IPC measures, and let's make it our business, because we indeed have a future to think of in terms of IPC. So thank you very much for joining us, and we look forward to having you again in our next sessions. Thank you, and God bless you, and have a lovely afternoon.